Please welcome Dr. Thomas ODorisio.
Thank you very much. I appreciate the opportunity and all the work that CCAN is doing and it has done. I think we're unique in the country to have the CCAN organization because they are really taking, like you heard, 24 conferences, and I think they're just outstanding. Every one that I've been part of, I've probably taken away 10 times more than maybe I've given. But it's a huge benefit to have them. I appreciate the lights going down because these are multicolored. I hope you can see them. When I had them made up, they told me that these are going to be AT&T slides, and that when the light goes down, these things are going to just jump out and touch you. Well, this is a true story. So when I got my bill, he reached out and gave me the bill. It was very tactile. I got kissed on the cost of them. So I want to make sure you can see every one of them. So what I want to share today is something that's in the book. It's called Theranostics. I'm going to show you a timeline and try to enflesh for you some of the people that brought this along over the last 110 years to the point where we now have, as we've heard twice today, excellent talks from Dr. Anthony and Dr. Woldering, personalized. You're starting to hear the word now, personalized therapy. And no better place, in my way of thinking, than in the role that theranostics play and with the compounds that we have available and have been using, as Gene said, since 1983, when the congener or analog of somatostatin, the body hormone, was made into an 8 amino acid structure called octreotide. We also have lanreotide. So I will touch on the options of care that you've heard about because I think it's very important to make a point, and you have the schema that many of you have already seen probably several times. But and every center offers the same type of algorithm or the options of care for you. But like I always say, a good option at the wrong time isn't your best option. This is the timeline just to show you, and you all have it. But it all began in 1902. There was a very important use of a radio isotope, which was called I-131 therapy, clear back in 1930, and the stage was set then to start to combine targeted radioactive therapy with proper organ, and in the case of the thyroid, I-131 is specific. In the case of the neuroendocrine tumors, the receptor is the, as we heard, somatostatin receptor subtype 2. And so we'll go forward just briefly through. I want to enflesh just a few of the people that I thought were very important in it. This is where the era began for hormones, and it was secretin was the very first hormone. Ironically, it's the most difficult to measure in the blood, and it looks as though secretin might be losing its impact in humans over the many years. But this was the first hormone described, and there was a graduate student that worked in the lab of the brother-in-laws, Bayliss and Starling, which I always think was interesting. And when they had this chemical messenger that stimulated other tissues, that's a hormone, by the by, when it goes into the bloodstream and then stimulates a target organ. He coined from the Greek military word hormone, which means I excite or I arouse to activity. And for us, that's where endocrinology began. Then this was an important physiologist named Edkins, J.S. Edkins. And Edkins was a physiologist, and he would work with animals, and he would scrape some of the intestine out and then put it back into an animal, and it would cause a lot of gastric acid secretion. And he identified gastrin as a hormone, and then kind of went into oblivion. Nobody knew afterwards what became of him, and that was in 1905. And then in 1907, Oberdorfer coined the term that we all know in this room as carcinoid tumors. It may have done more harm than good, but it comes from the German word Carcinoida, which means cancer-like. And that's because, as Dr. Jean alluded to, well differentiated. It looked an awful lot like normal, but it was moving through the bowel, or through the tissue in a cancerous way. And that's where the term cancer-like or carcinoid derived. Then a very important event happened in 1921 and 1922. Shown on the left is a medical student, Charlie Best. On the right is the physiologist, Dr. Banting. And they were able to stabilize insulin, which is a very important hormone, probably the very basic hormone for growth, just as somatostatin is the basic hormone for control. And the dog, I think, is Margot or Maggie. I'll have to ask Dr. Vinnick. But the dog had her pancreas removed. So she was urinating a great deal, as you do with sweet urine or diabetes mellitus. And so they were able to isolate the insulin from sheep, and this dog, is Maggie or Margot, is very happy now because she's getting insulin. And so her urination problem and the high sugars have stopped. Well, this was done in Toronto. And about 18 years ago, we visited the commemorating plaque where this picture was taken in 1921. And I was standing where Best was standing. And it's a hard thing to describe, but I closed my eyes to kind of get back to this moment of this major event of the stabilizing of insulin. And as I closed my eyes, I felt this warm, wet sensation down my leg. And I don't know, I can't say to this day what that meant, but it was really something. Now this was an important event clinically, because I told you about the neuroendocrine tumors of the bowel. That was the midgut, which we've heard a lot about this morning, and the great work that's coming out of Tulane, LSU with Jean and Lowell Anthony. And soon to hear Phil Boudreau's work that makes up their team. But in 1955, Robert Zollinger, Jean alluded to him, and his colleague, Ed Ellison, described two cases of a gastrin-secreting tumor from the pancreas. And it was coined the Zollinger-Ellison syndrome. But more importantly, and equally as important, it was the first description of a neuroendocrine tumor in the pancreas that was functioning and making too much gastrin. And Dr. Zollinger was forever frustrated because he tried for several years to isolate what he knew was gastrin, and he was unable to, by himself, to do that. The biochemist that worked with him and the columns to try and purify it would put it over the column, the extract, and then, go home for a day or two, and it would be destroyed on the column, and he was never able to make or identify what he knew was gastrin. Then this was happening at the same time of the gut peptide chemistry error. And Gregory on your left with his assistant Helen Tracy and Victor Mutt were making and isolating from hog intestine all the hormones that the physiologists were describing. And Dr. Gregory in 1961 was the first to characterize the 17 amino acid structure called gastrin. And remarkably, and with permission from the first tumor removed, was Ivory Wheeler. She allowed me to use her name, and she was in her 30s at this time. She was 17 when the tumor was taken out, when Dr. Zollinger did a subtotal gastrectomy and took out the target tissue, so she was not making ulcers or too much acid any longer. And she met Gregory because Gregory actually isolated the gastrin in part from her tumor. And that happened at Ohio State. It was a momentous time. And she got to meet Dr. Gregory on your left. And Miss Wheeler, I had the privilege and honor of taking care of her for 20 years. She passed at the age of 68. She was 17 when her tumor was isolated, and her stomach was, the target organ was removed. And she did not pass from her tumor. She had a different event that took her life. But I could never figure out why she had such high levels of gastrin in her blood to the very end, until I measured her somatostatin level. And she was actually making both somatostatin and gastrin. So she was actually controlling the action of gastrin with her own somatostatin. And it finally dawned on me that that's why she did so well with very minimum tumor spread. And then just to give a nod to Dr. Creutzfeldt, because he's done so much. Werner Creutzfeldt just passed, but he was a premier gastroenterologist and endocrinologist, and actually pioneered and established the role of glucagon-like peptide 1 as a major incretin of the GI tract. And as you now know, for diabetics, there is the GLP-1 mimetic called exenatide, and there's also a pill that breaks the enzyme down so GLP-1 can endure, which allows stimulation of insulin with a meal. And he helped pioneer this in all the years, but he was a major force in gastrointestinal hormones. Most importantly, he spawned a huge enthusiasm and spirit in Europe for neuroendocrine research. And I don't think it's any accident that there are now 19 centers of excellence in neuroendocrine tumors in Europe. We're fairly far behind in that regard, and I hope over time that'll change. But there are now 19 official centers, and I feel he was really one of the major forces in influences in Europe with neuroendocrine tumors. Here's the schema. You've all seen it. Everybody has an option of care. They've talked about it. It was shown on the board. But these are the different options that you have. And you can almost put months and years on every box and just add them up. So when you start to say, how long do I have, which is a dreadful term for me, when I talk to a patient for the first time in there, I don't look at it that way. I look at a series of options for a chronic cancer, as Lowell alluded to. And you add those up in the times you've heard survival times, time to progression, which is kind of a surrogate for overall survival with neuroendocrine tumors, because they are long-lived. You'll hear quality of life from Dr. Vinnick shortly, and how he's been able to assess living well with a chronic cancer, if you will. And we're going to touch on just a few, but I will end with the talk with the theranostic mechanism, both the concept, and I'll show you for the first time the gallium-68 DOTA TOC, or DOTA modified octreotide PET scan, which we've all been waiting for in the United States. They've done something like 13,000 in Europe. And we're very pleased to show you for the first time the results that we have. Problems with the neuroendocrine tumor therapeutic interventions, there are several. The decisions are made primarily based on the gold standard CT or the magnetic resonance imaging, sometimes ultrasound demonstration of disease progression. And it's the least sensitive, but it's the most important gold standard through which or from which decisions are made to go to the next option. Furthermore, symptoma is the word. Both symptomatic and asymptomatic changes are subjective by definition, and clinical signs, sometimes like art, are often in the eye of the beholder. My colleague, Dr. Jim Howe, our endocrine surgeon, you know, he just laughs at me every time I see him, because I always say at the end of when I see him and I introduce the patient, I said, yes, patient was flushing today. And, you know, he just shakes his head. And, you know, I see flushing in everything. And I guess so I say, it's there, it's there. So the tumor secreting amines and the neuropeptides, which we heard a great talk with Gene, are episodic. And that's something you have to remember. It's a hard word, it's a hard term. They're non-autonomous. They're not autonomous. That means that tumors, just like an insulin-secreting tumor, may behave very normally. So an insulin-secreting tumor with low sugar will turn off insulin, and when the sugar is high in the bloodstream, it turns on insulin. But then something happens. It starts to make more insulin at an inappropriate time. And all the neuroendocrine tumors behave that way. And nobody misses a high hormone in the bloodstream when the tumors are very much metastasized and they're now making a high product all the time. It's when they're very early in the symptoms, and Arthur has an amazing slide which hasn't, it's one of the benchmark slides from 1984 that shows that going into 12 to 18 years of a tumor growth, you may have variable symptoms of a carcinoid. You may have flushing, you may have some loose stools and it goes away for a while, but when it goes into the liver, then it becomes sustained. So that's a problem in when to catch it and how to catch it. Furthermore, calibrations, as Gene alluded to, of the radioimmunoassays of the neuropeptides is really a problem. We've worked very hard to try to make to have Inner Science Institute, over 40 years they've been doing this to calibrate the assays and become really important gold standards for measurement. And you heard this morning the difficulties now with other labs, knockoff labs, coming in, which lowers the price of their assay and increases the margin of profit for the hospitals, and so they start to send samples there. But that doesn't do us any good in terms of absolute numbers that we need, like for the neurokinin A assay that you heard about. So that's problematic, and so is the chromogranin A. There are 7 different labs now doing chromogranin A. So carcinoid tumors, very basically, serotonin is the most sensitive. It's episodic, as I told you, but for many years they made magic out of measuring serotonin. And then one day they added ascorbic acid into the tube, and it stabilized the ability to measure it and send it out and to measure it accurately. And for us, ARUP is an excellent lab, Quest is an excellent lab, Mayo is an excellent lab, and your serotonins can be reliably obtained if you have a midgut, mostly midgut, because serotonin resides, the cells that make serotonin are mostly in that small bowel area, jejunum and ileal area. 5-HIAA is a little bit cumbersome because you have to collect the urine for 24 hours. They can standardize it to creatinine, but it just has never caught on, where you could do a spot collection and calibrate it against the creatinine in the urine, and you could make it, you can commonize it or standardize it that way. And now the 5-HIAA is measured by high-pressure liquid chromatography versus the enzymatic method. There was an enzymatic method that would give very high levels of 5-HIAA, and now you have a more precise measurement, and it's not fraught with contamination, so you can measure it. In our experience, though, with 5-HIAA, we almost never see an elevated 5-HIAA until there's about at least 15% tumor in the liver, objective CT evidence of tumor in the liver. And so you have to be very careful in the interpretation of a 5-HIAA. It certainly isn't the first test that you want to do, although it's done, it's screened all the time with a suspicion of carcinoid tumor, but it's very, very far into the pathway for being helpful. And not only that, but you almost always have to have it metastasize to the liver in order to be measured. So the midguts are rich in serotonin, and so and I'll show you something that's kind of interesting in a moment regarding serotonin maybe in some of the pancreatic neuroendocrine tumors. But for the most part, serotonin is richly made from the midgut. So it becomes a very sensitive, maybe not totally specific without knowing if you have a tumor, but a very sensitive hormone can be measured. Foregut carcinoids, the ones we've heard about from the stomach and the lungs, and the pancreas have a few serotonin-containing cells. And the hindgut carcinoids have very, very few serotonin. So if you have a rectal or a large bowel tumor, serotonin is not a good screening marker for you, biomarker. We heard about chromogranin A, and it's a very important marker. Given its pure form, that there's no other things that could raise it, it's probably very good, as Gene has said this morning, for looking at total tumor burden, because chromogranin A is what gives the essence to neuroendocrine tumors. Chromogranin A means that these are well-differentiated cells. They look a lot like normal, but there's just too many of them, and now they're in a tumor, and maybe they've spread. So it's an excellent biomarker for perhaps extra liver as well as liver burden, tumor burden. It's one of the important points of chromogranin A is that it's broken down by an enzyme, prohormone convertase 1, and that enzyme appears to be up quite high in the liver, and it's with a liver metastasis. And as such, the earth person chromogranin A is cleaved and becomes pancreastatin. Now, pancreastatin we believe, is a very important hormone. It is a hormone. It has a biologic action as well in circulation, but it actually is a very early indicator of liver tumor activity. Not necessarily burden in the liver, but activity of the tumor, and it's a flag that we need to watch more carefully. It often precedes CT changes in the liver by 3 to 4 months, as Dr. Gene showed. Now, the pearls on chromogranin A are very important, and we forever get folks that have very high chromogranin A, and they're saying we think we have a carcinoid, and then you find out they've been on very potent proton pump inhibitors. Protonix, Acifex, Nexium is the strongest acid inhibitor, and the longer you're on these, the more chance you have of having high chromogranin A from cells in the stomach, not the tumor. And pancreastatin, as Gene showed, and we've talked about a long time ago, pancreastatin will not be abnormal in that case. Your chromogranin A will be, and the gastrin will also be very high. And there's so many times, but how you stop a person that needs it, sometimes you can't. Sometimes you can't take them off of proton pump inhibitors because of their reflux disease. So in some instances, I've actually just given short-acting sandostatin so they can stay on their inhibitor, which also, and give them sando, which helps lower the gastrin levels. I don't think it's good to walk around with high gastrin in the blood, regardless of the cause, because it causes things to grow, like stomach cells. And so the potential, or at least the theory, of gastrin-induced tumor growth is real in my mind. So just to mention the pancreastatin assay again, we were able to get it together with Dr. Vinnick and Dr. Woldering and Dr. Bill Goh and our colleagues from Inner Science Institute, and we were able to develop a very, very good assay for pancreastatin. And on the left side, you can see chromogranin A across the top does not cross-react with it, but you can measure pancreastatin very, very easily. And this is the figure that Gene showed earlier, but you could see the sensitivity of the pancreastatin assay because the patient's tumor was growing very subtly and it was picked up by pancreastatin, whereas the chromogranin A is 100 times less sensitive, and it was not seeing the changes that were going on in the liver. So it's one of the most important biomarkers in our armamentarium, and all who come to our places know that we always do those serial measurements for pancreastatin. In summary, on the markers, you've heard the chromogranin A level can reflect total tumor burden when it's metastatic for both pancreatic and midgut ileal tumors. And so the point is that, so you say, well, if I go to another place and I get a chromogranin A, how's that going to help me when I get it from another place? And the bottom line is that we can read trends. So if you're going to have a CGA test, get it from the same lab. And then you can see trends within that assay because it's the same lab that's doing them. Okay, you can read trends. It's not an all or none, but when you start mixing one assay, one chromogranin with another chromogranin lab, now you got apples and oranges and you can't compare them. Pancreastatin, we believe, is a very early and sensitive marker for liver tumor activity. And as you heard from Gene, neurokinin A is a predictor of a more aggressive midgut ileal tumor. And as you also heard, it can be modified. You can get it back into the normal range. You can come into that normal expectation of tumor progression. And that's what you most need to know, that you can change its behavior. And if you can't, you have to just get more aggressive, as you heard. Now, this is a paper, and I'm not going to get too far into Dr. Boudreau's work, but I wanted just to show you our initial experience with our midgut and our pancreatic tumors. Dr. Jim Howe is just completed our series of 113. Oh, I'm sorry.
That's okay. Let's see if I can plug that in.
Sorry.
That's all right.
Oh, I inadvertently unplugged it. Sorry.
Technical difficulties.
Thank you.
Get your overheads out.
Yeah. Turn the lights on. There, thank you. I'm sorry. Okay, good. Thank you. We finished, this is a series of 113 patients, about half pancreatic neuroendocrine tumors, PNETs, the other half midgut tumors. And what Dr. Howe decided to do was to compare the clinicopathologic factors features in the iNets and versus the PNETs, pancreatic versus the ileal, their behavior, survival stage at presentation, unknown primaries, risk factor assessment, and the role of the markers. We were doing the blood markers that I was speaking of, and this is what was kind of interesting. This is the most important slide to me, but and it's very difficult to read. I think it's on your handout. But if you'll notice, flushing was actually present in about 15% of the PNETs versus 44% of the iNets. And diarrhea was present in PNETs as well. These were classified as non-functioning. And then when we started to look at their characteristics when they presented with their pancreatic tumors. But pancreastatin, as you would expect, was very high in the ileal tumors. But it was also present at 57% of our patients. Again, the numbers were kind of small, but indeed it reflected liver activity. But the serotonin surprised us the most, and that is 96% of the midguts had high serotonin levels, and the PNETs, we were kind of shocked, had 56% had of the tumors, 26 of them, half, had high serotonin levels. Now, we're in the process now of looking at the tumors to see if we can stain serotonin from the tumors. We actually have now 4 cases, 4 folks who had not only primary pancreatic tumors, but also had primary ileal tumors. And so we believe, and this is Dr. Howe will go and examine the ileum and the small bowel very carefully on his pancreatic tumors if the serotonin is elevated. And we have found 4 with both primaries, secondary primary malignancy, whichever way you want to look at it. They were both neuroendocrine-derived tumors. And this is the metastatic comparison survival, 5-year survival, 72 versus 57%. These are, again, higher, as Gene alluded to, higher than the 5-year survival expectations reported by SEER. And you can see that, and those numbers really are not statistically different in the PNETs or iNets, but you can see the survival, 5-year survival is 72% for the pancreatic neuroendocrine tumors and 57% for the ileal tumors. And the ileal tumors have more often metastasized than the pancreatic tumors. That's also on the table. And lymph node involvement is more often involved in the ileal tumors than in the pancreatic. But the pancreatic tumors are bigger by size. That's the other thing on that last slide, bigger by size than the ileal tumors. So the conclusions Dr. Howe will publish in a month or two, it'll be out, is serotonin and pancreastatin are valuable in finding unknown primaries. Pancreatic neuroendocrine tumors have unexpectedly high serotonin levels with symptoms of diarrhea. So it's a symptomatic high level. Aggressive surgical approach and multidisciplinary team benefit in survival. And that's what we've heard again today, and we'll hear again from Dr. Boudreau. And 78%, as you saw, presented with distant mets versus 37% had distant mets to the liver, which surprises me because the pancreas is so close to the liver. I'd almost expect an automatic, and it's just not the case. But it is the case with ileal tumors going to the liver in a higher percent. And I'll just jump then to the other option of care, which is embolization of the liver, and one paper only, just to show you the benefits of a good option, namely Y90 sphere embolization. And this was the original paper by Salem from Northwestern and was published in 2008. He did a retrospective study at which was a 10-institution study. All of these were neuroendocrine tumors that were metastasized to the liver. He looked at radiologic, clinical, biochemical toxicities, and survival. He had 148 folks with 185 different Y90 embolization microspheres. These are the plastic bio-non-degradable. In Canada, the other one is called Theraspheres, which have glass beads with the Y90 attached. His results were no acute or delayed toxicity. Fatigue was the most common side effect. He found stable disease for 22%, partial response for 61%, complete response in about 2.7%, and progressive disease in a small percent of 4.9%. And I would say that's very impressive, that it's only 4.9% get worse with the embolization. Because if you look at the other side of PRRNT in Europe, you're seeing about maybe 15 to 20% progression with the PRRNT that we'll talk about. So this has a lower progression rate, which I think needs to be looked at when you're making decisions on which option of therapy is coming up. Median survival was excellent, is 70 months. So you can see that it's a wonderful option, especially when you start getting more and more liver tumor burden. And it's one that gives great benefit. Tim, it's perfect. And now their conclusion was Y90 is safe and it's to be considered. We obviously have hepatic arterial embolization using bland beads where you just put powder, and the other is dipped in chemotherapy. And we have a small abstract of the experience at Iowa at the NANETS meetings.